Welcome everybody to the new edition of the Surgical Ground Rounds. This is an evolution of the Surgical Ground Round, first introduced in 2019 for the residents in general surgery at the University of Padova. And now they evolve with the inclusion of the medical oncologists on this new perspective of Surgical Ground Round, including surgical oncology and medical oncology. So I would like to introduce the other moderator, Professor Rossana Berardi.
Thank you so much, Gaya, also for sharing with us your amazing project and also with the Università, Politecnica, delle Marche. We cannot leave surgeons alone, especially in those difficult diseases such as Colangiocarcinoma. This is a must. And today we will have the chance to discuss about this important topic with three opinion leaders in different fields. Please let's introduce the first one.
Tim Pollock is my mentor. But he first received his undergraduate degree from Georgetown University and his medical degree from Tufts Medical School of Medicine. Then he completed his surgical training at the University of Michigan and spent 2 years at Mass Gen as a surgical oncology research fellow. And then he completed his training in surgical oncology at MD Anderson in Houston. Dr. Pollock's main clinical interests include alimentary tract surgery with special interest on HPB. I had the opportunity to meet him during his time at Johns Hopkins in 2013. He actually took his first faculty appointment at Johns Hopkins in 2005, where he was professor of surgery and oncology, and then chair of alimentary tract disease and chief of the division of surgical oncology until 2016. He is now the chair of surgery at the Ohio State University Wexner Medical Center, where he holds the Urban Meyer III and Shelley Meyer Chair for Cancer Research. I cannot stop talking about how great he is and how a great mentor he was to me and to many other surgeon and doctor who had the chance to meet him. So thank you very much for being here with us today and discuss with us about what is your major, which is intraepatico Colangiocarcinoma. So welcome, Professor Tim Pollock.
Thank you so much, Dr. Spolverato. I'd like to thank you and the university. I'm really honored to be here today with the other esteemed the moderators and presenters. So my task is I'm going to talk a little bit about the surgical management of intrahepatic cholangiocarcinoma. So typically, at least in my practice, frequently intrahepatic cholangiocarcinoma presents somewhat incidentally. It's an intraparenchymal mass. Frequently, patients can have kind of non-specific symptoms. They may come into the ER, have a mass in their liver, and then someone puts a needle into it. The question is it a primary or secondary adenocarcinoma? So the hepatopathologist will try to look to see if they can identify some specific patterns with regards to the immunohistochemical staining to suggest that this is a primary intrahepatic cholangiocarcinoma. So they'll look for biliary dysplasia, but they'll look specifically for an IHC pattern that rules out other primaries like lung, colon, and pancreas, and then is much more suggestive of biliary epithelium. And you can see those markers on this slide. It is important, however, to always keep in mind that it could be an occult primary. I've had patients referred to me for intrahepatic cholangiocarcinoma who ended up having a gastric cancer or colon cancer. So one does need to rule out other primary tumors. Tumor markers can be helpful, but they're positive. The negative predictive value of tumor markers is actually fairly low. So in other words, if the tumor marker is negative, you can't be assured that indeed the patient does not have a cholangiocarcinoma. The positive predictive value is quite high. So in other words, if someone has a CA19-9 of 2000, it is unlikely that that is a false positive. But I do typically send off these tumor markers, and I do make sure that patients are up to date on their screening. So if it's a woman, a mammogram and a gynecologic exam. And then if it's an adult patient, I make sure that they're up to date on their lower colonoscopy. I use upper endoscopy much more selectively. And really the workhorse of this workup is cross-sectional imaging, CT, MRI, and then I actually do use PET a fair amount because I think it can be informative in instructing how to proceed, whether directly to surgery or with preoperative chemotherapy. In trying to think about cholangiocarcinoma, it's important to know that intrahepatic cholangiocarcinoma has three different morphologic subtypes. There's the mass-forming lesion that typically presents with capsular retraction. It's a hypotenuating mass, and you may see some ring enhancement. And then there's the periductal infiltrating morphology, which you can see enhancement and thickening of the bile duct. And then finally, the intraductal growth pattern, which is characterized by ductatasia and occasionally an intraductal papillary mass. But in general, when we're talking about intrahepatic cholangiocarcinoma, we're talking about the mass-forming lesion. This is a kind of a typical CT that you would see, a large lesion in the liver. These masses tend to be hypoattenuated early on, and only later in the later phases become more hypervascular. And then you can see some peritumoral ductal dilatation there. I favor MRI. Here's a classic example of an intrahepatic cholangiocarcinoma with capsular retraction, central necrosis, enhancement in the periphery in the later phases of the scan, and then peritumoral ductal dilatation. As I noted, I tend to use a fair amount of PET. These lesions are very PET FDG avid, and PET can help identify occult disease 20 to 30% of the time. And if patients have PET avid nodal disease in the perihilar area or in the celiac area, at least in my practice, I'm likely to treat those patients with preoperative chemotherapy rather than go directly to surgery. About 15 years ago, we put together the International Intrahepatic Cholangiocarcinoma Study Group, and my colleagues from Italy are a part of this collaborative. And operating on these patients can be difficult. Here's a patient, look at this lesion, very large lesion, central aspect of the liver. It's obliterated the right anterior portal vein, and it's abutting the right posterior branch. This patient would need an extended hemihepatectomy, and that's exactly what we did. You can see the umbilical fissure, the portal vein, the base of bile duct segments 2 and 3. Here is the explant. You can see sometimes because of the size and location of these lesions, obtaining a wide negative margin can be challenging. Here's another patient that I operated on. Large lesion in the left liver. Actually can't even see the middle or left hepatic vein on this patient. And I was concerned it could be possibly invading the vena cava. We actually treated this patient with systemic chemotherapy, Gem-Cis, and I actually gave this patient Y90 therapy also before operating on them. And then I took that patient to the operating room and performed an extended left hemihepatectomy. This patient is actually alive about 2 years after this operation. Here's another patient with a very different sad story, ending to the story. This is a patient with a large lesion in the right hemiliver, had obstruction, jaundice with a stent, had ascites, had a CA19-9 of like 10,000. This patient was also treated with preoperative chemotherapy, had a good response, had a CA19-9 come down to like 1,000. I operated on this patient and did a right hemihepatectomy, but this patient recurred within a year and has subsequently died. So when thinking of surgical resection, unlike hepatocellular carcinoma, it doesn't matter as much as whether you do an anatomic or non-anatomic resection, but what does matter is getting a negative margin. Data from our group, and you can see Gaya published this paper, demonstrated that patients who have a wider surgical margin have better long-term survival. And sometimes to achieve this negative margin, you need to do a vascular resection. And if you need to do a vascular resection of the portal vein and reconstruction, you should do it because these patients can have reasonable long-term outcomes. It just needs to be done at a major center because there's also associated increased morbidity with this procedure. So in the staging system for intrahepatic cholangiocarcinoma, up until the 7th edition, there was no staging system for intrahepatic cholangiocarcinoma. There have been some staging systems proposed by Japanese groups, but these were never validated in Western series. And then about 10 years ago now, we proposed a staging system for intrahepatic cholangiocarcinoma, and it was actually adopted by the AJCC. So everyone should be familiar with the current staging system for intrahepatic cholangiocarcinoma, and it's based on tumor size, number, and vascular invasion. Those patients who have a solitary tumor that's less than 5 centimeters, T1A, greater than 5 centimeters, T1B, and then if patients have vascular invasion or multifocal disease, that is T2 disease. And this staging system has been validated by our group and others and really should be considered the overall standard of care. Recently, we have proposed the tumor burden score, which is an aggregate score that assesses all the number of tumors in the liver as well as the size of the tumors in the liver. And we've shown that patients who have a high tumor burden have a 5-year survival of only 17% and a disease-free survival of only 7%. So I think this tool perhaps is helpful, again, to identify patients who may benefit from preoperative chemotherapy because patients with a high tumor burden have a prohibitively poor long-term survival even after curative intent resection. This is another study that we use machine learning and identified 3 different subtypes of intrahepatic cholangiocarcinoma. And we noted that those patients who have an inflammatory type of an intrahepatic cholangiocarcinoma, again, do quite poorly. So another category of patients who perhaps could benefit from preoperative chemotherapy. There's also been a lot of discussion about whether lymph node dissection should be done at the time of surgery. And if you look at data from our group and others, the overall incidence of lymph node metastasis is about 20 to 30%. And if you look at tools that our group and others have published to try to predict who has lymph node metastasis using preoperative data, it is very difficult, and these tools perform poorly. And we also know that even in patients who have T1A disease, early stage disease, the incidence of lymph node metastases is still about 15%. So similar to pancreatic cancer and colon cancer, we do lymphadenectomies for those diseases because we know that lymph nodes are very prognostically significant. And we have argued that if you do not find out the nodal status of the patient, you might as well not stage them at all. Because once they have node positive disease, what drives their prognosis is whether they are lymph node positive or negative, not whether there's vascular invasion or whether the disease is single or multifocal. So once you have metastases in the nodal basin, the T categories are not significant. As a surgeon, it's also important to know what nodal basins you should be resecting at the time of surgery. There is a laterality, if you will. So tumors on the right side drain typically into nodal basins 7, 8, 9, 12, and 13. So I typically harvest at least 8, 9, 12, and 13. And then tumors on the left side will also drain into nodal basins 1 and 3. So if there's a tumor on the left side, one should harvest those nodal basins also. And you can see here in this paper that we published in Annals of Surgery that not only the presence or absence of lymph node metastasis is important, but where the lymph node metastases are present. Those patients who have nodal metastases beyond segment 12 do significantly worse. So currently, the AJC recommends that you harvest 6 or more lymph nodes. But unfortunately, if you look at data from the United States, surgeons are only doing this about half the time. Only half of patients even have 1 lymph node evaluated, and only 15% of patients have the required or recommended 6 lymph nodes harvested at the time of surgery. And then I'll just end on outcomes after surgery. I think it'll be a good introduction into our next speakers, because even after all of this, big resections, doing extended hepatectomies and trying to get a negative margin, doing a lymphadenectomy, the overall cure after resection remains quite poor, only in the range. And there's another paper that Gaya published in Cancer of about 10%, because patients will recur. And if you look at their long-term survival, it's not too dissimilar to pancreatic adenocarcinoma with the 5-year survival in the range of 30%. And that's because most of these patients will recur. They recur often, and they recur early. And if you look at the patterns of recurrence, half of recurrences will be outside the liver, an extrahepatic recurrence. And that's why chemotherapy, targeted therapy is so important for this disease. And if we're going to make progress like we did with colorectal liver metastasis, it may not come on the side of surgery. It's more likely to come on the side of chemotherapy, immunotherapy, targeted therapy. And even if you look in this paper that we just published in JAMA Surgery, 1/5 of patients are developing a recurrence within 6 months of a liver resection. So I think, more and more we need to use different tools to better identify who is at risk for recurrence, especially early recurrence. And perhaps instead of offering those patients surgery up front, we should be offering those patients chemotherapy first to better delineate their biology, and then having kind of adjuvant surgery, if you will, rather than operate first and then adjuvant chemo. So hopefully what I've shown you is that intrahepatic cholangiocarcinoma is a very challenging disease for surgeons to deal with. These patients often present late in their clinical course with large tumors requiring major hepatectomies. One should strive at the time of surgery to obtain a negative margin, if necessary, to do a vascular resection, but do that at a center that has experience doing that. And then I feel strongly that all patients should have a lymphadenectomy at the time of surgical resection. And one should tailor the lymphadenectomy based on the location of the tumor in the liver, but strive to at least harvest 6 or more lymph nodes to be consistent with what the AJCC, UICC recommends for the surgical management of this disease. So with that, I'll conclude my comments. And again, I'm really grateful for the opportunity to be with you all here virtually today. And I look forward to the other speakers' presentations and discussion to follow. Thank you.
Thank you so much, Professor Polik, and congratulations for your presentation. Now we can leave the floor to Dr. Nicola Normanno, who is Director of the Cell Biology and Biotherapy Unit at INT Fondazione Pascale in Naples and Chairman of the Translational Research Department. Dr. Normanno's group is also involved in clinical diagnostic and in the organization of national and international external quality assessment schemes in molecular pathology. He is the president of the International Quality Network for Pathology and past president of the Italian Cancer Society. Dr. Normanno is also author of more than 300 publications in peer-reviewed journals. But first of all, he is a national and international opinion leader in the particular field of molecular biology in oncology. And he is a great researcher as well as a great friend. So thank you so much, Nicola, for being here with us, and please have the floor.
Thank you, Rossana, very much for this nice introduction. I will try in my short talk to touch some of the points that might be relevant for the discussion. And let's start from the point that our knowledge of genomic alteration of biliary tract cancer, in particular cholangiocarcinoma, has significantly increased over the past few years, and in particular it has been possible to identify a number of actionable genomic alterations, which the actionable genomic alterations are those alterations that allow us for a therapeutic intervention. Now, as shown in this slide, the type and the frequency of genomic alteration is quite different between intrahepatic cholangiocarcinoma, exhepatic cholangiocarcinoma, and also gallbladder cancer, not shown in this slide. And there have been a lot of discussion in the field whether we should limit molecular profiling only to intrahepatic cholangiocarcinoma, because most of the drugs that we have available are actually directly against targets that can be identified in these subtypes. In this respect, the recommendation, the guidelines from the European Society of Medical Oncology really help to solve the problem, because these guidelines do recommend to perform molecular profiling in all biliary tract cancer. And these are the 6 targets we should test in our routine clinical practice: IDH1 mutations, FGFR2 fusions, MSI, NTRK fusions, BRAF mutations, and HER2 amplification. In fact, these are genomic alterations are ranked as SCAT level 1. The SCAT, this is the ESMO scale for clinical actionability of targets, and in the level 1 we found those targets that are ready for clinical implementation, which means there are sufficient data to support that the presence of this biomarker does predict response to a matched target therapy. What I want to highlight is that only for 3 of these biomarkers we have drugs that have been approved by the European Medicines Agency, and some colleagues are really questioning whether we should test for all these biomarkers. My point is that it is possible to access to drugs that have not been approved by EMA, maybe through expanded access, special funds from the Italian Drug Agency, clinical trials. So it's really worth that we screen our patients for all these 6 biomarkers. What about the techniques we should use for screening? Here, the ESMO has been very clear since 2020, suggesting that in clinical practice we should use NGS for molecular profiling of cholangiocarcinoma. And actually, in this recommendation, there are 3 points that need to be highlighted. First, that if RNA-based NGS is available, that's better, in particular for the assessment of the fusions, in this case FGFR2 fusions. The second is that the panels that are recommended by ESMO to be used in clinical practice should be small panels focusing on level 1 alterations. However, the ESMO is also recommending that in academic centers, larger panels should be used for molecular profiling of cholangiocarcinoma, hemogeneric or cancer patients. What is the difference between small panel and larger panel? Well, to show this difference, to explain this difference, I will show you some preliminary data that have been published in the European Journal of Cancer a few days ago from the Rational study. The Rational is the National Register of Actionable Mutations. This is a study that we launched a few years ago and to which many Italian researchers are participating, including the center led by Rossana Berardi. Now, this study enrolled patients in 2 different pathways. In pathway A, we just enrolled patients who had an NGS test in clinical practice, and most of these patients received a test with a small panel below less than 50 genes. In the pathway B, we enrolled patients that did not have access to NGS, and these patients received a testing with a comprehensive genomic profiling panel, the Foundation 1 panel. Now, as shown in this slide, there is no really difference in the detection rate of level 1 alteration in pathway A and pathway B. This is because even small panels will cover efficiently the level 1 alteration. But if we move to level 2 or 3 alteration, then in the pathway B, we can detect much higher number of these alterations that might allow to put patients on clinical trials. Now, 19% of the 738 patients that were reported in this initial study are at biliary tract cancer, and this is a detail for the cholangiocarcinoma. If you look at pathway B, which had 101 patients, 30 were positive for level 1 alteration, and this result is in line with what is expected from a number of different studies. So a huge fraction of patients can receive a therapy that is matched to genomic alteration found in these patients. There are also 17 level 2, level 3 genomic alterations, and these are all alterations that, as I told you before, may allow to put patients into clinical trial. Another important point of discussion is when we should perform genomic profiling of cholangiocarcinoma, I would say, biliary tract cancer patients. Now, the recommendation is to perform profiling at diagnosis. There are some colleagues that argue that not all patients will get to a second-line treatment, and all the drugs, the target-based agents that have been approved up to now, are for second line. But if you wait that patients has progression of the disease to perform genomic profiling, then that might be too late in order to give a target therapy to these patients. Another issue that also has been raised by some colleagues is that these patients are receiving a first line of chemotherapy and maybe chemo and immunotherapy. And so while we are doing the test on the tumor diagnosis, we should maybe get another biopsy at progression of disease. The fact is, however, that most of these mutations, IDH, BRAF, FGFR, are usually clonal mutations. They are in very early events in the process of cancerogenesis. They are present in 100% of tumor cells, and there is no proof that either chemotherapy or immunotherapy can change the genomic profiling of a clonal alteration. Therefore, it is recommended to test patients at the diagnosis on the specimen that has been used for the initial diagnosis. In some patients, we might not have available tissue for genomic profiling, and then we can use liquid biopsy. These are data from my centers, almost 500 patients tested in the past 2 years with the liquid biopsy. Most were lung cancer. We had quite a few also colangiocarcinoma patients, and with the new NGS panels that have been developed to test cell-free DNA, to test liquid biopsy, you can pick up any kind of genomic alteration, mutations, fusions, or copy number variations. However, we know that the sensitivity, in particular for fusions and copy number variation, is relatively low. And this is why ESMO did recommend that in the clinical practice, self-sequencing liquid biopsy should be used only if a tissue is not available or if a fast response to test is required. In fact, we have to acknowledge that testing of liquid biopsy is much faster as compared with testing the tissue. However, looking at the results of the liquid biopsy, we should really carefully interpret such results, taking into account the possibility that false negative findings can be due to low levels of circulating the tumor DNA. Now, last part of a few slides of my talk is to address one of the issues that Rossana asked me to cover, which is the current status of NGS testing for colangiocarcinoma in our country. Actually, we don't have any database that in which we can access to address this question. So what I'm going to do is to show the results of a survey that International Coordinating Network of Pathology performed together with the European pharmaceutical the European Associations of Pharmaceutical Industries and Associations and the European Cancer Patient Coalition. Actually, we performed this survey a couple of years ago between 2020 and 2021, and the data have been published in 2022 in the European Journal of Cancer. What we did was to assess the status of a number of biomarkers in all European countries. The biomarkers in Tier 1 are either PD-L1, BRCA, EGFR, NTRK, but also NGS hotspot or NGS comprehensive panels, and these biomarkers were investigated in all European countries, and then in selected European countries we also assess the status of other biomarkers, HER2-ARC, MMR, MSI, ROS1, BRAF, KRAS, NRAS, and liquid biopsy. Now, to make short a long story, this is what we found. Actually, in many European countries, there are some limitations in access to precision medicine. In Italy, the main problem is the huge delay between the EMA approval and the availability of the drug for all patients, the reimbursement of the drug. Quite surprisingly, we still have limitations in the access to single biomarker tests. In Italy, we found significant difference between northern and southern Italy, and in particular this is in part due to lack of reimbursement of some simple tests such as immunohistochemistry. There are some issues related to quality, ISO accreditation, as well as the participation to external quality assessment schemes, but one of the major problem that we found in Italy and many European countries is the access to NGS that is highly limited. And these are the detailed data for NGS in Italy. Although the availability of the different technologies, hotspot, panel, comprehensive, is not bad in Italy, the uptake in 2020-2021 was only 2%, which means that only 2% of the patients who had a test for a biomarker were tested with the NGS. Now, this is mainly due to at least two different issues. On one hand, there is really a lack of facilities and expertise in running NGS, with a huge difference between northern and southern Italy. On the other hand, there is also a clear issue related to reimbursement, because only few countries really identified a specific budget for the reimbursement of NGS tests. Now there are many initiatives at regulatory levels, new laws that have been released. Maybe we can discuss this later on, but one of the initiatives I would like to highlight is this, that is a rather global initiative, a Lancet Oncology Commission, in which we will try to identify the barriers to the implementation of precision oncology worldwide, and we will propose some solution to try to remove these barriers and to allow all cancer patients to access to new technologies for diagnosis and treatment of cancer. And my final slide is just to acknowledge my collaborators and all the investigators who participated to the rational study, and in particular the group of Rossana Berardi, who gave a great contribution. Thanks for the attention.
Thank you so much, Nicola. Really, thanks also for the great job you are doing in Italy with the rational study, but also with your efforts in trying to develop a standardized pathway. And thank you for being generous in giving us many suggestions when we need. And now it's the turn of the medical oncologist, and with a great pleasure, I'm introducing a collaborator of mine, Dr. Alessandro Parisi, who is a consultant medical oncologist at the Department of Oncology at Università Politecnica delle Marche. He is fully involved in gastrointestinal oncology, with a particular interest in clinical and translational research, and a particular interest in cholangiocarcinoma as well. In fact, he is leading a national project of research on this topic, in analyzing the real life data in this type of disease. So please hand the floor, Alessandro.
Thank you, Professor Berardi. Good evening, everybody, and thank you, Professor Spolverato, for the kind invitation. I feel small among giants. However, I will show a rapid overview concerning the paradigmatic shift we are managing with in the systemic treatment of biliary tract cancer, particularly intraepathic cholangiocarcinoma. These are my disclosures. So let's start from the recent publication of the new ESMO guidelines concerning diagnosis and treatment of biliary tract cancer. As previously told, the radical surgery represents the cornerstone in the early disease, followed by adjuvant chemotherapy with capecitabine, which produces a statistically significant, even if clinically questionable, survival benefit, with an absolute survival in terms of 5-year overall survival of about 3%. In the locally advanced or metastatic setting, the association of cisplatin and gemcitabine still represents the standard of care, eventually associated with the PD-1 inhibitor durvalumab, according to the positive results of the TOPAZ-1 trial. Particularly relevant in the locally advanced setting is the need to properly reassess the possibility to perform a radical resection if we obtain a disease response after 3 to 6 months of systemic treatment, because this might further prolong survival, as we know. In the never operable or clearly metastatic setting, on the other hand, to date, the priority, if we want to say, is represented by the need to offer the patient a molecular profiling, as told previously. And this is something unthinkable until a few years ago. With this respect, it is auspicable the use of a NGS panel of at least low to medium dimension, analyzing about 50 genes, which should at least analyze the mutations for which there is the possibility to use targeted agents, at least within clinical trials. Indeed, with the exception of the use of the FGFR2 oral inhibitor pemigatinib as second line of treatment in patients whose tumors harbor FGFR2 fusion or rearrangement, or the agnostic approbation of larotrectinib and entrectinib in TRK-positive tumors, or even pembrolizumab in MSI tumors, all the other potentially active agents are not reimbursed to date, at least in Europe, by EMA. As told previously, durvalumab has been tested in association with cisplatin and gemcitabine compared to the standard of care alone in the randomized double-blind placebo-controlled TOPAZ-1 trial. The association with durvalumab provided a statistically significant, even if in a certain way, clinically questionable benefit in overall survival in the overall population, 12.8 versus 11.5 months of median overall survival, with a reduction in the risk of death of 20%, with a 2-year overall survival of about 25 compared to 10%. So we could say a great benefit for a small number of patients, and it would be important to identify and better select those patients who really might benefit from the addition of durvalumab, even for a cost-effective management and the issue of sustainability. But no predictive clinical or molecular biomarker are viable today with this respect. On the other hand, particularly intriguing, the higher objective response rate in favor of the durvalumab arm, even for the possibility to potentially induce tumor shrinkage and convert to surgery tumors not amenable to be treated with upfront radical surgery. All these efficacy and activity results were related with no striking differences in terms of adverse events, and particularly to immune-related adverse events, mainly endocrine and thyroid related immune-related adverse events such as hyperthyroidism, in line with previous findings from chemoimmunotherapy trials. As already emphasized previously, a paradigmatic shift has been happened in the knowledge of tumor biology, even in biliary tract cancers, from histology and anatomic-driven heterogeneity, which historically distinguished intraepatico from perihilar and distal cholangiocarcinoma. Today, we can speak of biology and molecular-driven heterogeneity. And under this point of view, we can further distinguish biliary tract cancer-specific and disease-agnostic molecular alterations, such as FGFR2 fusions or rearrangement and DDH1 mutations, particularly frequent, as we know, in up to 15 to 20% of intrahepatic cholangiocarcinoma, but even BRAF2 and KRAS mutations besides tract fusions or microsatellite instability. A turning point in the molecularly oriented management of biliary tract cancer has been signaled by the results of the 5202 phase 2 trial, in which patients with advanced or metastatic cholangiocarcinoma progressed after first line of standard of care chemotherapy and known FGF, FGFR1-3 fusion rearrangement or mutations were treated with the FGFR2 oral and reversible inhibitor pemigatinib, producing an objective response rate and disease control rate of 55.5% and 82% respectively, with median progression-free survival and overall survival of 7 and 17.5 months respectively in the course of patients with FGFR2 fusions or rearrangements at the final survival analysis. After these exciting results in assessing of cancer patients with several unmet needs, other selective and reversible FGFR inhibitors have been tested, such as infigratinib and futibatinib, with similar interesting activity and survival results. Besides FGFR2 fusions, as told previously, up to 15 to 20% of intrahepatic cholangiocarcinoma harbor ADH1 mutations. In the randomized, double-blind, placebo-controlled phase 3 Clarity trial, evasadinib provided a relevant clinical benefit in pretreated biliary tract cancer patients harboring ADH1 mutations. Despite the high rate of patients in the placebo arm who crossed over to ivosidenib at disease progression, at the adjusted final survival analysis, the ivosidenib arm still maintain a relevant benefit in median overall survival, about 10 compared to 5 months, with a relevant improvement in quality of life analysis and no particularly treatment-related adverse events. Multiple ongoing phase 1-2 trials are testing different strategies to target HER2-positive tumors, from the association of pertuzumab and trastuzumab to the association of trastuzumab and chemotherapy with FOLFOX, and the use of trastuzumab deruxtecan with encouraging results in terms of disease control rate and objective response rate. With respect to BRAF mutation, the TAPUR and the ROAR basket trials are testing the anti-MEK, anti-BRAF association of cobimetinib, morafenib, and trametinib, and abrafenib, respectively, leading to a high rate of objective response rate and disease control rate and promising survival outcomes, even in the cholangiocarcinoma cohort. but the evolving landscape of molecular targets will require progressively larger DNA and RNA panels. Indeed, besides the known activity and efficacy results of NTRK inhibitors, interesting preliminary results have been observed with energy inhibitors and RET inhibitors. To conclude, the treatment paradigm of biliary tract cancer is rapidly evolving, and the use of immunotherapy and targeted therapy is progressively taking off besides chemotherapy. With this respect, molecular profiling should be performed earlier in the metastatic disease, and if possible, even before in the early disease, since biliary tract cancer inevitably relapses in the great majority of the cases, despite a radical resection and adjuvant treatment. In parallel, the need for matched therapies is an ongoing issue, and not always a specific molecular alteration can be effectively targeted by specific agents. Instead, the contrary is the truth, since only a small fraction of patients underwent an NGS assessment, even with big panels such as Foundation One panel, is then effectively treated with targeted agents. Of course, this cannot certainly happen in a clinical practice setting. So thereafter, an implementation of even academic research impacted trial is desirable and auspicable. Thank you for the attention.
Thank you very much, Dr. Parisi. I have a couple of questions that I would like to ask to Dr. Normanno and Professor Polik. Do you have any suggestion on the type of biopsy in order to have an adequate diagnosis on our patients? Tim?
We just do a core biopsy.
Just do a core biopsy? And is that it's enough to have an adequate sample for an histological diagnosis and a molecular diagnosis, Professor Normanno?
Yeah, actually, that would be sufficient. I have to say that most of our patients do not get a core biopsy. We see a lot of cytology specimens, fine needle aspirates, and so on. So the issue now is really that what should be clear to everyone with access into a biliary tract cancer, that if you get a molecular profile of your patient, that can make a difference. Because if you find an NTRK fusion, so you find one of these strong drivers, you can give an important opportunity to the patients. Now, through that, we can also look at that by liquid biopsy, and actually Colangiocarcinoma, because of the anatomical localization, is a tumor that is shedding quite much the DNA in the blood. But we know also from data that been recently published that the sensitivity for some specific genomic alteration, in particular for FGFR2 fusions, is very low. So you really have the chance to miss this alteration if you don't have tissue available. So I do believe that tissue and liquid biopsy will integrate the information, but we need to push to have sufficient amount of tissue to have a good histology, but also a very good molecular biology profiling of all patients.
Thank you for clarifying
this. So we typically
this.
try to get tissue preoperatively so we can get that information.
Thank you.
We agree with you.
So which is the role, if there is any role, of the liquid biopsy, Tim?
Well, I think as Dr. Normanno said, the problem with liquid biopsy, sometimes it can miss, my understanding is FGFR fusions. And so, we prefer to get a molecular profile based on actual tissue rather than liquid biopsy. I don't know if in the future, liquid biopsy will also be used to more prognostically stratify patients after resection, as is being done with colorectal liver metastasis, to see if, it disappears once you know what you're looking for. I think that will prove to be helpful in the future. But right now, we don't use it a lot. We much more depend on tissue biopsy.
Yeah, we use quite a lot also because sometimes if we cannot really perform profiling of the primary tumor, and we go with the liquid biopsy, let's say you pick up an IDH mutation or a KRAS mutation, they are mutually exclusive usually with the FGFR fusion. So that's will help in deciding whether or not to go for another biopsy. And that's what we do actually in our practice.
Well, we know that biliary tract cancer guidelines since last year have introduced the molecular profilation for all patients in advanced or metastatic stage of disease. Therefore, I wonder whether, I'm asking to all the three experts, which are the minimum that we need to know in order to treat in the best way our patients, and how to face this recommendation with reality, because we know that reimbursement is a real barrier in molecular profilation, in particular with NGS, at least in Italy, but I wonder whether it is the same thing in the US. And the situation is, as we know, jeopardized in different regions. And to my eyes, this is mainly due, on one hand, to the fact that it is important to include tests in the so-called LEA, that means the essential level of assistance, that include few genes at the moment, and very gradually they include the possibility to have a reimbursement, in particular with NGS. And the other point is that we have centers and centers. I mean, the expertise may be different, and also on the point of view of molecular biologists. So how to manage this complex situation?
It's very difficult to address this question. Now, let's say that there are a number of national initiatives now, like the identification of referral centers for NGS in almost every region. So that should help to at least identify centers that should have the capability to perform NGS testing. For reimbursement, we don't have a national policy for reimbursement. Every region does whatever it wants, and there are huge differences. However, what I can tell, what we did is that when there is a drug that's been approved and requires a biomarker, we assume that biomarker then becomes standard of care. And of course, we don't have FGFR, but we don't have even, for a long time, we didn't have even EGFR in the LEA. Still in the LEA, there are no EGFR. There is also in the list of reimbursed tests. So what we do, we just sum up the different sequencing code that we have available, and we try to make a reimbursement fee for the NGS. And that now you have 3 drugs that have been approved, so you can sum up those 3. I understand that this is not the best way to go, but this is some suggestion that I can give also to other labs in order to get some kind of reimbursement. On the other hand, these are rare cancer, but very aggressive cancer. I mean, I think that we should do all that we can in order to provide the best treatment to these patients. We don't want to miss any patient. I guess that team in the States, you have a coverage from insurance for this type of test. It should not be a problem, right?
Yeah, that's correct. So, Medicare and other private payers do cover for NGS, especially as Dr. Normanno highlighted that there's specific drugs now, right? So, we don't have typical problems getting reimbursement.
Yeah, and Rossana, we should find a similar way when a drug gets into the guideline, or in the case of ESMO or Italian guidelines. Right. At that point, the test must be reimbursed. Right. Makes no sense. Otherwise, you have the drug, you don't do the test. How can you treat the patient? Makes no sense, really.
Yes. As I thought previously, in my opinion, there's a matter of sustainability at different levels, from the number of genes we should test via DNA or RNA NGS, to the need to better select patients who are really likely to benefit from durvalumab association with cisplatin gemcitabine. So the matter is really complex in my opinion. To date, we don't have predictive instruments, both clinical or molecular, that could help us to better select this kind of patients.
Thank you, Alessandro. And you show several data about new therapy that have become a reality in cholangiocarcinoma. And you are also collecting real data about pegmigatinib treatment. And we also have a great opportunity with immunotherapy. So therefore, I wonder whether you can share with us your feeling about real life and clinical experience outside clinical trials, if the new therapy really represent an important tool for our patient, and something about manageability.
The MNDI approval of the first-in-class oral and reversible FGFR2 inhibitor pemigatinib is strikingly modified our clinical practice. First of all, told several times previously, because it is now essential to test for at least the most common molecular alterations in biliary tract cancer, at least during the course of an advanced or metastatic disease setting, but even before, if we have the possibility. In this regard, it is desirable the possibility to test, to use at least a small or better medium-sized both DNA and RNA NGS panel, including EDH1, HER2, BRAF, FGFR2, and TRAC genes. Of course, a proper assessment of the cost-benefit ratio of the panels should be done together with anatomopathologist and molecular biologist. MSI status can be tested by immunohistochemistry of the DNA mismatch repair protein. On the other hand, the use of pemigatinib in advanced or metastatic biliary tract cancer patients with FGFR2 fusions or rearrangements has radically changed the prognosis of these patients with long-lasting disease response and patients who still are in response after 1 or 2 years since the beginning of the drug. And 2 cases I'm managing with are still on treatment after 2 years of therapy, and where are heavily pretreated patients. And this was unbelievable until a few years ago. Of course, the use of FGFR inhibitors has raised some concerns regarding the management of some class-specific adverse events, such as nail or cutaneous or ocular toxicity, which may sometimes impair quality of life if not properly managed with dose reductions, discontinuations, or with a close multidisciplinary management with both dermatologists and ophthalmologists.
Thank you, thank you. To you all, how can you improve the way we take care of patients and the timing? I know that there are 2 different scenarios, the Italian scenarios and the American scenarios, but which are your opinion on these?
I mean, I can give my opinion. I mean, I think that we need to head towards more, at least what we have in the United States, for a paradigm for pancreatic cancer. Pretty much 100% of my pancreatic cancer patients are treated with neoadjuvant therapy now. I think, we need to select patients much more appropriately for surgical resection. And I think moving towards giving more therapy up front, whether that's traditional chemotherapy like GemCis, or ideally more targeted immunotherapy, or FGFR, therapy, BRAF therapy, whatever it may be, upfront makes sense to me. And then operating on patients. Because as I show, like 1 in 5 patients recur within 6 months of a major liver resection. It seems like we can do better than that.
Better patient selection. What do you think, Dr. Normanno?
Yeah, I fully agree, and to cut the time, I think that we should introduce molecular profiling as soon as possible as a reflex test, really. I mean, when, we work only, all of us work in reference centers, when there is multidisciplinary team with patients is metastatic, immediately, together with diagnosis, you should cut the slide to send to the molecular biology lab and start with the molecular profiling. And actually, I do understand that is a matter of cost, but the cost of a medium-sized panel would be maybe 800, 900 euros. If you go to a comprehensive genomic profiling, you go to 1,500 euros. That's it. If you compare with the cost of immune therapy or target therapy, it's nothing. And you can get a lot of information. For example, we know that P53 mutations are associated with worse outcome, even in patients receiving target therapy. We don't know whether this is because of predictive or prognostic value of these co-alterations. But precision oncology in the future will not rely on a single mutation, but on the comprehensive genomic profiling. So I think that even, few academic centers in Italy, if we start to work together and we do comprehensive genomic profiling, we will understand a lot on how to better handle these patients in the future.
And of course, centralization is pivotal,
yes.
Right?
Yes, I totally agree with Professor Normanno and Polik. We should anticipate as soon as possible molecular profiling to the curative setting, since more than 20% of patients radically resected inevitably relapse. So we need to be ready when the disease relapses to treat in a better way for patients.
Thank you.
So we are going to conclude, and thank you so much for giving us the opportunity to share your knowledge with us. This webinar was really interesting, and we are sure that a revolution, a real revolution, has started in this field, in this particular disease. New drugs, new biomarkers, a multidisciplinary approach, more and more complex. In the meantime, I do believe that we need to continue to act at different levels to improve the patient journey, and this in terms of access to the therapies, as well as to the possibility to be to perform a good profilation. And I do believe that this may be done at hospital and regional level. In this sense, we can try to work together in order to identify expertise, increase expertise, especially in hub centers, and to improve also our multidisciplinary pathways. It is important to underline that pathways are important, but also the possibility to increase the quality of them. I'm speaking about that because our hospital in Ancona has been recently granted as Best Public Hospital in Italy from Health Ministry, just because we are working hard in order to perform an improvement in terms of quality. And I do believe that quality is important as a main objective. In the meantime, I do believe that at national level, working together is necessary in order to increase homogeneity within the regions, among the regions, and we have seen a jeopardized situation that needs to be covered, because the patients need to have and to receive the best care without observing differences between region and region. And finally, we have not discussed it, but I do believe that it is important to act also in the context of molecular tumor boards and increase the possibility to create a real network between the different molecular tumor boards in the different regions. So thank you so much, and I'm leaving the floor to Professor Gaya Spolverato for the conclusions.
So thank you, everybody. It was a great pleasure to have you here. It was a great pleasure to discuss about a new approach to intrahepatic cholangiocarcinoma in this setting, in these surgical ground rounds for all the surgical and medical oncology community, and for all the doctors and people who take care of oncological patients in this country and abroad. Thank you to the sponsor who made this possible, and I'll see you all in the next session. Thank you very much.